Everyone. Welcome to our session today at CSA. This session is called Exploring Local and Global Community Crisis Intervention and Response. I'd like to begin with a land acknowledgement. While we meet here on a virtual platform, we should take a moment to recognize the importance of the land on which we are each located. We acknowledge the territory to reaffirm our commitment and responsibility in building deep, positive relationships with nations and in developing a deep understanding of Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all Inuit, First Nations, and Métis people. We invite you to learn more about the territory on which you reside at nativeland.ca. So before we begin, I would just like to go over some Zoom rules. For this session, Zoom is generating closed captioning and it's available under live transcript, so you can click that. Please save your questions until after the presentations. We have time allocated for Q&A at the end. You're welcome to use the chat feature to type your questions, or you can raise your hand if you wish to speak. Throughout the session, please keep your microphone and camera off unless you're invited to speak by the session chair. And you can turn on your mic and camera during Q&A if you would like. Yeah, thank you. All right, so I'm going to share my screen. All right, so I'm going to hand it over to Jessica to begin.
Hi, folks. Really happy for those of you who have joined us to be here and hear a little bit about the work that we've been doing over the last year and a bit. My name is Jessica Evans. I'm an assistant professor in the Department of Criminology at Toronto Metropolitan University, and I am the project lead on this kind of project that we're going to be presenting to you today called Who Can I Call? This is gathering the evidence on crisis intervention, questioning involuntary treatment, and minimizing harm. Some of what we're going to be presenting today has been kind of influenced by broader discussions within Ontario, within BC, of expanding the remit of who can be captured under involuntary treatment. And this is in response to a growing number of individuals in our community who experience behavioral or substance-related crises. And so what we wanted to do is partner with the Gerstein Crisis Center, which my research assistant Mediha is going to talk to you a little bit about in a moment. But we wanted to partner with a community-based crisis intervention service to start to document the kind of strategies, the interventions, and the outcomes of community-based non-coercive forms of crisis intervention. And so we had today planned for us three separate presentations looking at three distinct factors or kind of aspects of our project. As some of you might know, the data collection process is hardly linear. And so while we were hoping to have some pretty concrete findings to present to you today, a lot of what we're going to be discussing is in terms of preliminary findings. We have finished collecting our data for the most part. We are moving into analysis and we have some preliminary ideas, but I just want to kind of flag as a caveat that we are still kind of finalizing our analysis. And so feedback is really appreciated today. And hopefully we'll still be able to share something that is interesting and worth your time. And so having said that, I'm going to pass it back to Aisha and Mediha. They're going to take you through some of the setup for this project, how it came about, what we're trying to do. I'm then going to lead you through what we've done so far in terms of a literature review and a scoping review of the literature. And then Aisha is going to close it off by talking about some of our preliminary findings from an analysis of Gerstein Center crisis client files. So I'm going to turn myself off now and I'm going to pass it over to Aisha and Mediha.
All right, thank you, Jessica. So this is our project team. We've partnered with the Gerstein Crisis Center, and today we have Jessica, Mediha, and myself presenting on the various components of this project. This research project is based on a collaboration with the CERC in Health Equity and Community Wellbeing at Toronto Metropolitan University and the Gerstein Crisis Center. All right, so this project has been funded and supported by the Canada Excellence Research Chair in Health Equity and Community Wellbeing. It is also supported by the TMU Faculty of Arts and the Social Sciences and Humanities Research Council of Canada, or SSHRC, has also awarded this project a Partnership Engage grant. I'm going to talk a little bit about the CERC. So led by Dr. Karen Soldotich, the Canada Excellence Research Chair in Health Equity and Community Wellbeing is a transformative research initiative that employs an engaged community partnership approach to expand our understanding and practice and delivery of health outcomes for all members of our communities. Through collaboration with a network of healthcare institutions, service providers, civil society organizations, this program aims for a paradigm shift, one that challenges a siloed, expert-driven approach to health and well-being and moves instead towards a community-engaged, preventative model of well-being. We uniquely apply a critical disability lens, and the research program aims to not only reduce health disparities that are inextricable from their social context, but also to embed community knowledge into healthcare institutions, systems, and models of delivery. So I want to talk a little bit about the social determinants of health and community well-being at the CERC, which is also where this project's sort of situated. So the social determinants are conditions under which people are born, grow, live, love, work, and age, and include factors such as education, employment, and social support networks. Structural determinants of health are the broader sociopolitical, economic, and ecological context that shape these more proximal social determinants and in turn shape population health and well-being. Sure, that's a little wordy, but that's the definition from the World Health Organization. So drawing and expanding upon WHO's definition of the social determinants of health, we expansively consider the social, so conditions of living throughout the life course, structural, which includes sociopolitical, economic, and ecological contexts, as well as the indigenous determinants of health. For instance, the loss of land, climate destruction, whole community health, the role of reconciliation, and the role of culture and language in health, and so much more. And how all of these interact in complex ways to produce health outcomes. We also consider the interplay between these, such as how the social location and living conditions are influenced by structural factors that determine a person's vulnerability to risk, the resources that are available to them, and other mitigating factors that will come to light as we present on this project. Research in this stream aims to understand how inequitable social factors and relations are reproduce themselves, becoming entrenched, but may ultimately also be disrupted. So this stream at the CERC encompasses the United Nations Sustainable Development Goal 3, or SDG 3, which is good health and well-being to ensure healthy lives and promote well-being for all. And if you take a look at this diagram that we have here, there are several components that contribute to the social determinants of health, including spatial dynamics, socio-identity, barriers, housing, accessibility, income, education, gender, culture, race, and so much more. It is a long list, but it also includes community-driven models of health and well-being, which is central to this project. So here, we focus on addressing the social determinants of health of crisis care service users and advancing upstream preventative models of care through a critical disability and intersectional lens. And by partnering with Gerstein, which Medea will talk about in a second, we're hoping to investigate non-medical crisis interventions and substance use crises, which usually are prioritized in approaches to mental health in a medical or a carceral context. But here we're mirroring the healthcare delivery paradigm shift in the WHO's new guidelines on mental health, and we're also aligning with the central objectives of the CERC in health equity and community well-being by kind of stepping away from looking at medical and police-based interventions. So one of the CERC's mandates is to bridge academic research with community-driven solutions and fostering this preventative model of well-being that centers equity and accessibility. All right, so I'm going to hand it over to Medea to kind of talk about crisis response.
Yeah, so first I'll be talking about crisis response. Current crisis response frameworks typically rely on police intervention, often leading to the criminalization or unnecessary hospitalization of individuals experiencing mental health crises or substance use-related distress. These approaches fail to address the complex social and economic factors that contribute to crises, particularly for people who have historically been underserved in society. In Ontario, the increasing frequency and intensity of crises stem from multiple structural issues, including a worsening housing crisis, a growing opioid epidemic, and insufficient financial support for disabled individuals. Our research seeks to explore alternative crisis intervention models that prioritize non-medical, community-led responses without police intervention, thereby addressing a significant gap in policy and practice, which also speaks to the conference's theme of justice begins early as we advocate for policy change with evidence-based research. Many individuals in crisis experience multiple intersecting challenges such as mental distress, substance use, financial instability, and social exclusion. Current crisis response strategies also disproportionately impact racialized and disabled individuals who are also at the highest risk of being harmed or killed during police interactions. Despite widespread recognition that law enforcement is ill-equipped to serve as first responders for mental health and substance use crises, Ontario continues to rely on punitive measures such as involuntary treatment programs and the closure of supervised consumption facilities rather than evidence-based right-centered interventions. This brings us to our project, Who Can I Call? Our title is an ode to our first team meeting where we had a discussion which led to the question, during a crisis situation, does the public or do our communities know the alternative organizations or numbers to call instead of the police? The answer is that for the most part, people only know of 911. A part of our project is to definitely shed light on alternate pathways to access community-driven care. And this is highlighted by this visual representation. The access points all look at the same, but they are different in terms of processes, care, support, and impact. This project is a two-stage project between a multidisciplinary research team and Gerstein. Stage one has various components, including a literature review on involuntary treatment, a scoping review on community-based crisis interventions around the world, narrative profiles built from one urban crisis center's internal data, and a study of crisis worker interviews. The second stage will focus on mobile care teams and involve additional community partners. This presentation is focused on stage one because that's where we are right now in our timeline. Gerstein Center is an urban crisis care organization offering a range of services and programs, including a telephone crisis line that receives more than 30,000 calls per year, mobile care teams, community-based crisis beds, referral services, peer-led group activities, and more. Gerstein has been around for 35 years, and they provide 24/7 crisis intervention services, ensuring that individuals experiencing a mental health crisis receive immediate and compassionate support. Their right-centered approach emphasizes non-medical, recovery-oriented care, which aligns with the partnership's goal of fostering person-centered, accessible health services. A 2023 case study by Human Rights Watch pointed to Gerstein Crisis Center as an exemplar of community-based mental health crisis support. So this map provides a high-level overview of what Gerstein Center is. If people are having an immediate crisis in the city of Toronto, they're welcome to call the 24/7 line. There you're connected with a crisis worker who can walk you through a crisis situation that you're currently experiencing on your own, or if a loved one is, a family member, a colleague, etc., as long as you're over the age of 16. Gerstein has two direct lines, the crisis line number, as you can see on the screen, as well as 988. They are one of the partners in the National Suicide Prevention Line, so they have trained community crisis workers that are able to receive those calls and walk someone through their crisis. Also attached to the services is a mobile team, so these teams can come out and see you, and crisis workers can meet with you in real time and guide you through your crisis. Gerstein also has crisis beds attached to their service where people can get a little bit of rest for 2 to 3 days and kind of regroup, get the support that they need in-house, and then they're able to return back to their home or wherever they may be staying. There's also crisis support at the Toronto Public Library, which offers low-barrier crisis support and programs to library customers in a welcoming and judgment-free environment. Through this partnership, GCC and the Toronto Public Library, also known as TPL, provides crisis management and follow-up support, referrals and community connection, and peer-led recovery groups, activities including finding recovery through exercise skills and hope, and wellness recovery action plan called RAP for the program in 4 TPL branches. The crisis team can help with short-term counseling, mental health support, primary care services, connecting with housing workers, substance use support or resources, financial and employment support, and wellness recovery programs. Gerstein does a lot of community collaboration. Their work is very much guided by people with lived experience and living experience, and they also have a variety of advisory groups to help guide that work. So the philosophy behind each of their programs is that Gerstein Center has an approach to crisis that respects the individual's ability to define their own identities, experience, and goals. Hence, they follow a strengths-based approach, which is based on coordination, equity, and access, empathy, collaborative problem solving, and harm reduction. This project co-develops solutions with Gerstein, a frontline support service provider, and therefore this project, through this collaboration, not only advances evidence-based alternatives to involuntary treatment, but also strengthens the capacity of community organizations to advocate for systemic change, reflecting CERC's broader goal of transforming health systems through participatory, justice-oriented care. This first stage involves 4 central goals. Build on evidence based on non-medical crisis interventions without police and carceral responses, identify, map, and document key features of effective non-medical crisis interventions, drawing upon international models explored within the literature. Collate existing evidence on appropriate harms and benefits of involuntary treatment for mental distress and or substance use crisis care, and to generate new knowledge about the experiences of people who access non-medical crisis support and their short and long-term outcomes by conducting and analyzing interviews with community crisis workers and conducting an in-depth case study of client records, feedback forms, and aggregate reports and interview data. So our research questions for stage 1 are essentially broken into 2 categories: effective non-medical crisis interventions and involuntary treatment for mental distress and or substance use. We're essentially looking for key characteristics, gaps that exist between literature and practice, demographics of Gerstein service users, etc., and who accesses crisis services in Toronto, what social factors led them there, what policy recommendations can be made, what existing evidence suggests about the harms and benefits of involuntary treatment for mental distress and or substance use crises. Our research activities include a scoping review focused on international models of alternative crisis interventions, a literature review on involuntary treatment for mental distress, and after conducting analysis of GCC's underused internal data, we will create narrative profiles to understand the realities of how people experience community-based crisis interventions. We're analyzing client workers' feedback forms and aggregate reports, and also interviews with Gerstein's workers in several programs. Combined, this data will better inform Gerstein models of service delivery in addition to contributing to the development of evidence-based public health policy responses to mental health and substance use critical crisis care. This study is grounded in anti-racist feminist theory, mass studies praxis, and survivor research ethics, emphasizing the lived experiences and agency of those impacted by crisis interventions. Additionally, critical criminology and qualitative health research methodologies will guide our analysis, challenging medicalized and carceral approaches to crisis response while highlighting structural and systemic factors influencing harm reduction and service accessibility. This project will use thematic and narrative analysis, thematic analysis for the on-site records, and the narrative analysis for interviews.
All right, thanks so much, Madiha. So I'm going to take over from here, and I'm going to bring us through some of the data that we've collected so far in terms of the lit review and the scoping lit review. So the first thing that we started off with was a literature review that just aimed to broadly understand what evidence currently exists in support of or against coercive forms of treatment. So when we speak about coercive crisis intervention, what we're speaking of is, one, the use of police, arrests, and use of force to intervene in people experiencing behavioral or substance-related crises. We're also speaking about involuntary admissions to emergency departments, involuntary treatment. We are speaking of seclusion and the use of physical, mechanical, or chemical restraints. And these are all practices that currently are widespread in mental health services globally. However, there is really very little evidence that suggests these practices have any benefit, while a significant body of evidence suggests that these cause further forms of trauma, whether that's physical trauma, psychological harm, dehumanization, a worsening of mental health symptoms, as well as eroding trust in social services. And this is certainly something that we saw quite a bit in the case files that we reviewed as well. Aisha is going to speak a little bit more to that coming up, but certainly a repeated feature in those crisis files that we were looking at, which were anonymized, just to be clear, was that people were afraid of dealing with the hospital. People were afraid of dealing with police. People were afraid of dealing with doctors and a variety of social service providers. And certainly involuntary treatment and coercive interventions into people experiencing crisis is only going to kind of strengthen those aversions. We are also kind of drawing off of the WHO's guidance on mental health policy and their strategic action plan, which was released in March of this year, that suggests that, or rather March of last year, which suggests that a comprehensive mental health policy and crisis intervention strategy should involve training for mental health professionals to understand the harm caused by coercive practices. There's a need to develop capacity to implement non-coercive practices. There's a need for effective communication in crisis situations, individualized planning, recognizing that people come to crisis from a variety of different avenues. There's a need for support in the form of the creation of crisis response teams. And there's a need to ensure quality assessment and improvement of existing crisis programs. And so taking on from the WHO guidance, this is some of the stuff that we're looking for in our scoping review as well. In terms of what we've actually found with the literature review on coercive crisis intervention practices, one, we have found that there is broadly a lack of credible and reliable evidence to support its use. In general, there's been a critique of the methods that have been used to kind of test these programs. There's been inconsistency across the programs, the outcomes, the variables measured, et cetera. When we do see trials and studies analyzing the outcomes of involuntary treatment, oftentimes there are significantly low numbers in the trials and loss of participants during follow-up stages, which again can impact the reliability of the data. Overall, we see that there's a lack of randomized and controlled studies on involuntary treatment, lack of control groups or comparison groups, et cetera. One of the interesting things that comes up in the literature on involuntary treatment, and specifically the literature in favor of involuntary treatment, is the idea that one of the positive outcomes associated with this is people spend more time in treatment. So retention in treatment seems to be the primary positive outcome affiliated with involuntary treatment. But of course, people are spending more time in treatment because they have been mandated to do so. And so this is an outcome that for us doesn't necessarily pass muster. Some interesting points that we do see in the literature on involuntary treatment is in relation to demographics. So unmarried men diagnosed with alcohol or opioid use disorders faced heightened risks of being subjected to involuntary treatment. And one of the kind of conclusions that seems to be alluded to in the literature here is that there is a significant role then to be played by social stability and community connection and contact as a way of kind of protecting from and preventing crisis, or for protecting and preventing situations leading to crisis outcomes. There's also concern that a focus on involuntary treatment will divert the necessary funding and attention away from programs that emphasize voluntary treatment. And certainly within the literature on kind of community-based crisis intervention strategies, this is one of the dominant critiques. We've been doing interviews with crisis workers, and one of the things that's come up a couple of times now is that They have so many people that they deal with on a daily, weekly basis that are just waiting for voluntary beds in treatment, but we don't have beds in treatment available. And so another critique of involuntary treatment that comes out of this literature is that there are probably more people that would be willing to voluntarily engage in treatment, whether that's behavioral or substance related, and that we should be focusing on opening up space for people to engage voluntarily rather than focusing on creating more spaces for involuntary treatment. And so that was kind of just the basic literature that we review that we did to look at involuntary and coercive crisis intervention practices. Again, what we found overall is that there is very little compelling evidence to support this. And in fact, the only measure that is kind of positively correlated with this is retention in treatment. But one of the things that we find as well is that people are more likely exiting involuntary treatment to overdose, to die from overdose, and to die from other causes. And so now we want to move into doing a scoping review on non-carceral, non-medical crisis intervention. So to start off with, we had a discussion as a team, and the team includes our community partner, the Gerstein Crisis Center, and their executive director, Susan Davis. And as a team, we kind of sat down and discussed whether or not we were trying to do a systematic review or a scoping review. And we concluded that a scoping review would be more appropriate for our needs at this point in time. We're not trying to necessarily ascertain which particular community strategies are the most effective or have the best outcomes. Rather, we're trying to map what currently exists within the evidence base of community-based crisis interventions. So we're looking for things like, how do alternative crisis care services even define crisis, right? What is a crisis? Or rather, what are the goals and values of alternative crisis care? So what are the ethics that underpin this? What are the objective outcomes? When we look at medical-based interventions, oftentimes the outcomes that are desired or the goals are a reduction in symptomology, right? But reduction in symptoms, i.e. the behavioral issue or the substance-related issue that was kind of most visible during crisis, those are often effects of something that is kind of under the layers, which we talked about before in terms of social determinants of health. So we know that the goals of crisis care in more traditional senses tend to be reducing symptomology. We want to get a handle on what those goals look like for community crisis care programs. And then the final kind of objective of the scoping review was to kind of ascertain and map the range of tools and strategies that are used in alternative crisis care. And so the guiding question for can we go back for 2 seconds? The guiding question for our scoping review is, what is the current evidence base on non-coercive crisis care? And again, here we're looking just to map strategies, goals, values, definitions, and those kinds of things. So we considered methodologically how to approach this. We looked at both the Joanna Briggs Institute or JBI guidelines as well as Cochrane guidelines for a scoping review. We ultimately chose to follow JBI guidelines here. Some of the key considerations were, I think scoping reviews, they originate in the health sciences and they tend to be set up for more clinical, or rather the evaluation and the mapping of clinical studies. However, our kind of our research area sits at the intersection of health sciences, but also social services and social sciences. And so the range of literature that we're looking to collect kind of expands beyond just traditional kind of clinical studies to involve or include gray literature from community-based organizations doing this work, as well as a variety of forms of more narrative kind of qualitative research in addition to clinical studies. As a result, we found that JBI has more explicit guidance on how to incorporate non-traditional sources of information into a scoping review. We also appreciated that the JBI framework operates, or rather has as a complement, what they refer to as their active framework, which is authors and consumers together impacting evidence. This is guidance in how to incorporate non-academic or non-traditional academic actors into the scoping review process. And we found that this complemented our strategy, which is a community engaged partnership with a crisis service center. And so we actively kind of bounced ideas around, search terms and so on and so forth with the wider research team, which included service providers. And then finally, We decided to go with JBI simply because software. We are currently using Covidence to track our progress for the scoping review. And Covidence was effectively set up to support JBI. Cochrane can be supported with additional subscriptions and purchases. So for all those reasons, both pragmatic as well as kind of theoretical, we decided to follow JBI kind of methodology for the scoping review. In terms of establishing our search terms for the scoping review, we went with the kind of PICO framework, so population, intervention, outcome. I can't remember C, I can't remember off the top of my head for C, but we focused predominantly on trying to identify populations and interventions. So the population that we were trying to capture in the literature as we were searching were people experiencing substance or behavioral or mental health related crises. And so I won't go through all of these terms, but you can get a sense of the variety of terms that we kind of use to search for this literature. The other kind of search term that we were really interested in was obviously around the intervention. Here, we were trying to conceptualize different ways of framing or phrasing non-medical, non-police crisis intervention. And as an aside, if someone has a quicker, kind of easy terminology for that, please do throw it in the chat as a suggestion. I think we've settled on non-coercive crisis care for the moment. But we're trying to think of a way to capture kind of what we're thinking about in this. The other thing that we needed to keep in mind as we were looking through the literature is that we are focusing on an adult population. And this is simply because the kinds of requirements, the strategies, et cetera, for juvenile or pediatric populations are going to be quite different from best practice for adults. And so we felt those warranted separation. So moving on to our inclusion and exclusion criteria, we established the following parameters that would help us decide which articles we're going to keep in the scoping review that meet our criteria and that help us to answer our question, and which we're going to exclude. The first was that we wanted our program or intervention. So if we're looking for a study, the program or intervention or interventions that the article is discussing has to be available to the general population. So in the course of doing our search, and I'll show you in a few minutes how many articles we started off with, but there were a lot of very specific types of interventions. So one thing that came up quite a bit were interventions for people with eating disorders. We also saw a lot of interventions specific to veterans, as well as interventions specific to the COVID-19 pandemic. And while the lessons learned from those may well carry over, once again, there's probably going to be some very specific details there that aren't as useful for this kind of wider, more generalized crisis intervention that we're trying to capture. And so we have limited our inclusion to studies that address crisis intervention, community crisis intervention services that are available to the general population, not specific populations. The second criteria, sorry, we're going to go back. I'm still going through that. The second criteria that we wanted to hit on is that the program or intervention is community-based and it is non-coercive. It is completely voluntary. Our target population is 18 or older. In general, we have tried to keep it to that. Nonetheless, some programs do operate for people aged like 16 to 27 or something like that, or 16 to 25. These are like the young adult population, I suppose, is what they're referring to them as. And because that does include part of the population that we're trying to capture, we did include those. We wanted to make sure that the literature that we're including documents existing non-coercive community crisis care programs or practices. So another thing that we came across quite a bit in the literature was, articles that are theoretically or historically making the case for non-coercive crisis care. We excluded those because, once again, we're trying to map what crisis care looks like in a community-based setting without the use of coercion. We're not looking for the justifications or why we should be implementing that. So we would exclude literature that was addressing this at more of a theoretical or conceptual level. This the literature that was included here is both academic and gray literature. We looked for English language only publications, and so this is going to be a limitation of the scoping review. And we're looking at articles that were published between 2019 and 2025. We want these to be fairly current and recent, but we also think there might be something interesting to note in the pre-COVID and post-COVID kind of context. And so we wanted to keep that kind of 5-year time span, or rather 6-year time span. In terms of exclusions, once again, if the program is population or issue specific, we excluded it. If the target population is under the age of 18, we've excluded it. If the intervention involves any kind of police or hospitalization, we have excluded it. Any non-English publications we excluded, and we also excluded publications, obviously, published prior to 2019. One gray area in the inclusion-exclusion criteria is that we've obviously tried to focus on non-medical interventions, but when we say non-medical, what we're referring to is non-coercive medical interventions. And so interventions that include street nurses, for example, those would be included in our study. Interventions that require hospitalization, transfers to ED rooms, and so on and so forth, those would not be included. And so in terms of the scoping review, we started out with those search terms and found a total of 848 articles from a variety of different sources, which you can read on the slide here. Once we found those 848 articles, we removed 273 immediately because they were duplicates. We then had 574 articles that we moved to the title and abstract screening. Here we reviewed the title and the abstract as we might expect, and we removed several more from here. So by the time we completed our title and abstract screening, we had excluded an additional 455. So that has led us to the full text review stage where we had 119 articles. So far, we have reviewed 40. I think we have accepted 10. And so we're just finishing up our full text review, at which point we're going to move to our data extraction. And before I get into data extraction, I'm going to hand it over back over to Mediha. What I was just showing you was how we've gone through the academic sources. The gray literature sources were a little bit more difficult to navigate, and Mediha has been doing a really fantastic job. And so she knows that very well. And so I'm going to turn it over to her for a couple of slides to explain how we've incorporated the gray literature into our scoping review.
Yeah, so we also looked at potential gray literature sources. We searched for organizations surrounding mental health resources and crisis interventions globally and organized them into a spreadsheet. We ended up with 199 organizations in total. Our approach was to read through each source and look for any organizations or crisis intervention models that are mentioned or discussed. We then examined the effectiveness of each approach to crisis interventions. After searching for literature from all organizations, we were able to find 138 resources to be screened. Because gray literature sources aren't in the database in Confidence, and we were not able to locate many of those sources, we decided to upload them and screen them manually. We created a spreadsheet, as you can see here, that allows 2 reviewers to screen each resource and choose a reason for exclusion. Out of the 20 screens so far, we have 4 of them that showed evidence for crisis interventions and are within our scope of study. So we're still in the beginning stages for this. We found that the ones that we excluded so far did not describe any crisis intervention techniques or strategies in practice. For example, how the intervention is being implemented, but instead they just list their services and resources. In terms of crisis interventions we found globally, there were a few that were mentioned many times and stood out to us. I know we talked a lot about Gerstein, but there were some that we saw many times in the global setting. So Babu Trust is an organization in India that provides programs for low-income communities. Mind Freedom Ghana seeks to provide, improve upon the social, moral, and economic conditions of persons with psychosocial disabilities and deal with the stigma they suffer. Open Dialogue is in Finland, and it aims to meet with people in crisis within 24 hours of contact and daily until the crisis is resolved. Hospitalization is avoided, and the Open Dialogue team works with the client and their social network throughout the life of the problem. In addition, people are offered other therapies as required, for example, employment support, individual therapy, occupational therapy, etc. One of the gray literature sources that was screened to be included in our study is from an organization called Crisis that is based in the UK. and it focuses on preventing homelessness. What is great about this resource is that it first discusses ways to prevent homelessness, particularly during critical life transitions, such as leaving prison, hospitals, or care systems. It provides evidence for the effectiveness of critical time intervention CTI model, citing research showing improved housing stability for people receiving CTI support during transitional periods.
And so just wrapping up on the literature and scoping review, we are now also starting to pilot some options for charting the data. What we initially did is because we had 10 approved articles in Covidence, we trial run the Covidence extraction form intended for scoping reviews. However, we found that this too was geared too much towards clinical trials. And so the data that it was seeking to extract was less relevant for the goals of our study. So we did a little bit more reading. We looked at JBI kind of guidance, and we are moving towards more of a qualitative content analysis and coding in order to extract data. Again, this is guidance provided by Peters et al., as well as others, that sometimes what we're trying to extract from a scoping review is less clinical, it's more descriptive, it's more narrative, and it may well be better suited to a more qualitative coding strategy. And so right now, some pilot parent codes that we're developing and that have been developed inductively from our familiarity with the literature are things like we'll capture year of publication, study type, study aim. We want to capture how crisis is being defined. We want to capture the goals and values of effective crisis care. We want to capture the different techniques or tools that are involved in non-coercive crisis care. We want to be able to capture the range and map the range of actors that are involved in this process. And this is actually really interesting because one of the findings that we have, one of the anecdotal findings that we have right now is that a very large portion of crisis care work is service liaison. Helping to attach people to services, helping them to navigate the bureaucracy and red tape of services, and so on and so forth. And so, recognizing this, we're recognizing that there's a larger map of actors that are involved in the process of crisis care beyond the people that are immediately there in the point of de-escalation. And then finally, what are some of the barriers and limitations of non-coercive crisis care? Where does it perhaps not work? What are some of the structural issues that kind of prevent non-coercive crisis care from operating as effectively as it could? Before I kind of hand this off to Aisha to talk a little bit about the client files, I'll just say once again, very anecdotally, but having, gone through these articles several times now, some of the emergent themes that are coming out to me right now are one, the prioritization of collaborative decision making. People in crisis need to feel like they are involved in resolving that crisis, and that is important both for trust in the immediate moment as well as for the long-term potential outcomes. If people are not buying into the solution to their crisis, then they're not going to follow that. And so if people are incorporated into the process, we tend to see better outcomes. Other key facets that come out of the literature are things like harm reduction, the need for empathy, the need for service liaison, material resources that address immediate needs like housing, food security, transportation, etc., as well as conflict resolution and de-escalation, supportive listening, and counseling. So again, very anecdotally, but those seem to be the major kind of component pieces that are emerging from the scoping literature review. I think our goal is to have these literature reviews out for publication by the end of the summer, but we'll also have some summaries of this in the final report that we'll be releasing in the fall as well. And so having said that, I'm going to pass it over to Aisha, who's going to wrap it up for us with a discussion of client case files.
All right, thank you, Jessica. So our project also draws from 4 internal sources of data from the Gerstein Crisis Center. So these include client records, Ontario Perception of Care or OPOC forms, high-level demographic data, and interviews with community crisis workers. For the client records, we're looking at 50 that range from 2019 to 2025 for stays at the St. Charles location at Gerstein. These sections include summary notes, history, and presenting issues. And this data set allowed us to identify key gaps in the social determinants of health that may assist in developing upstream solutions for service users. We're looking at 44 Ontario Perception of Care, or OPOC, feedback forms. The OPOC is a tool to collect care feedback for clients receiving publicly funded mental health, addictions, and or concurrent disorder services in Ontario, and it helps to inform quality improvement initiatives. So this includes for both hospital and community-based services such as Gerstein. We were able to get 44 de-identified OPOC forms, and this data allows us to build a composite profile of the client satisfaction and outcomes after receiving non-coercive crisis intervention. Since the OPOC is conducted ad hoc by Gerstein, the batch that we're analyzing is from early 2026, and Gerstein was able to collect 44 of them. We're also looking at high-level demographic data, which provides from system-level reports that provide demographic and operational data. It offers a macro-level perspective on Gerstein's crisis services, and this analysis helps us identify and illustrate the trends in service use over time, which is beneficial for highlighting gaps and providing recommendations. And the last piece of data that we're looking at is also from 15 to 20 community crisis worker interviews. And we're conducting these interviews right now. We're done about half of them, and we have the rest of them scheduled. They are mostly over Zoom, but we offer the option of doing it in person or over the phone, depending on the preference of the participant. These are qualitative interviews, and all of the data that we're collecting is de-identified. So no identifying information appears in any of the research outputs. This data really helps us provide insight into the operation and impact of GCC programs, as well as the rich qualitative data regarding both the experiences of accessing services and those who are providing it. And so we're about halfway through those. And the findings that we're going to discuss today, we're looking at the preliminary analysis of the client records. After rigorous de-identification of the files by Gerstein's data specialist, our team reviewed 50 client records for their summary notes, history, and presenting issues. All right, so here you can see the template which we use to go through the client records. Essentially, we're trying to capture the experience or events. What are the systemic and structural issues leading to someone's crisis? What we also found was that there were quite a few clients that at Gerstein that have actually been there for a very long time, in the sense that they kept coming back and using the services. So, there will be activity for a month or 2 months, and then silence for maybe a year or two, and then they come back to Gerstein. So that date range is pretty wide. We're also looking at the relevant client history, intervention strategy, what is really different from the biomedical or police interventions, outcomes, locations that are mentioned in the client record. So that could include the subway, parks, where they're staying, on the street, where are they? People who's involved in the story, their family, friends, neighbors, doctors, etc. What is the narrative? So what we would do is, especially with the large files, right, is that they would be, we had files that were more than 50 pages, close to 100 pages. We would read through the entire thing and try to really capture the essence of the story of this person. We're also looking at what's significant to note. Is there anything that stands out here? And what are the challenges? What's blocking their barriers? What is causing barriers for support? So as we're making our way through analyzing what we've captured, we're using the software Deduce. And so far, from what we've coded, we've generated this word cloud that highlights the common themes this far across the client records. And as you can see, supportive listening, equity and access, as well as service connection navigation are some of the ones that stand out, which is also something that we noticed from the scoping review and the literature review as well, and as what Jessica and Medea have highlighted too. And I'm going to expand on these in the next one. All right, so the majority of case files that we reviewed showed that individuals are extremely proactive in trying to change their situations, but encounter numerous systemic issues that can trigger acute crisis. We've identified 5 key categories of crisis service users that can. So the first one is individuals with immediate housing issues. The second is individuals in need of someone to help liaise and advocate with social services. This include case management, the landlord and tenant boards, the LTB. The third one is individuals in need of supportive listening, de-escalation, and check-ins. They don't have anyone to check in on them, and having Gerstein doing that check really helps them move through the crisis situation that they're in. The fourth one is individuals in need of immediate resources. So this can include food security, snacks, transportation, so transit vouchers. The fifth one is an individuals supporting a loved one in crisis. And so they'll reach out to Gerstein for someone who that they know can benefit from Gerstein, and they're not sure of how to support them, so they turn to Gerstein to liaise with that individual. Okay. So I'm going to bring this map back from the previous slide to highlight our findings and how they align with the Gerstein model and how someone moves through this. So Gerstein does a lot of community collaboration. Their work is very much guided by people with lived experience and living experience. And they also have a variety of advisory groups that help guide this work. So the philosophy behind each of their programs is that the Gerstein Center has an approach to crisis that respects an individual's ability to define their own identities, experience, and goals. Hence, they follow a strengths-based approach, which centers on coordination, equity, and access, empathy, and collaborative problem solving, harm reduction as outlined in this visual. So we found that each of these values factor into the crisis approach, and we're going to walk you through an example. So we have Tom, who has just been evicted from his apartment and he has nowhere to go. He calls the crisis line and explains his situation, including that he feels this eviction was groundless and he did not receive proper warning. He has no place to go and is feeling desolate. The initial call includes speaking to a crisis worker who ensures supportive listening and de-escalation, thereby reducing harm and engaging with empathy. They offered to do intake for a crisis bed the following day and set up a meeting between Tom and the crisis team, so harm reduction. Intake involves discussing what the issue is and what the individual wants and what to do about it. So beyond a short bed stay, which is between 2 to 5 days. So options might be trying to help Tom get legal aid to address the unfair eviction, connecting him to a case manager and or housing shelter and lists. This embodies collaborative problem solving, care coordination, and empathy, as well as focusing on the next steps around Tom and his own autonomy. Okay, so this project definitely has a lot of moving parts to it. We're about halfway through crisis worker interviews at the moment, and this is our preliminary analysis for both the client records, for OPOC, for the interviews, and for the scoping review. So our key takeaways include that community crisis response combats harmful stereotypes and really helps in navigating social services. Many of the concurrent issues, the intersection challenges that individuals in crisis face can be engaged with community connection. And this needs to be reflected in resource allocation and policy. We're being intentional with our outputs to make sure our findings and final report are received at a community level as well as at a government level beyond academia and centering knowledge from those with lived experience. There is a lot of bureaucratic red tape that prevents one from being able to navigate the system, and it becomes even more challenging to do so when in crisis and one feels that they've been backed into a corner and they don't have anywhere else to go. And it's in those times that community crisis care alternatives, such as the Gerstein Crisis Center, are so important in filling these crucial gaps. I also wanted to share one of our community outputs. We'd like to invite you to listen to our Disability Dialogues podcast episode on this topic. You can stream it on Spotify, and here's the QR code to do so. Disability Dialogues is a podcast featuring CERC researchers discussing research in a public-facing format in order to make research findings accessible, but also why the average person should care about co-creating inclusive healthcare and well-being within their communities. And this particular episode is titled Rethinking Crisis Response, Building Community-Led Alternatives in Ontario. And it's with Jessica, our principal investigator, as well as Susan Davis, the executive director at Gerstein, who's also a co-PI on this project. This episode came out last September, and it sets the stage for this project. We're hoping to release another episode later this year to discuss our findings a year later in a narrative format. So please stay tuned for that. This brings us to the end of our collective presentation. Thank you for participating and listening. Our contact information is on the screen, as well as our project page and our published OSF protocol. So please feel free to check that out. I believe we now have about 30 minutes for questions. So feel free to use the Q&A function on Zoom, and feel free to ask us any questions in the chat as well.